Thank you very much for this opportunity to present about disease modeling in Alzheimer's disease. In particular, we've been working on this for the last several years within the roadmap collaboration, in particular, work package 4. I have on the slide deck the abstract that I believe was sent out to you, which is describing the literature review component, but there's also the roadmap component as well. I would like to first start off this presentation with a big thank you to the Roadmap Collaboration Consortium for contributing the content for this presentation. And this reflects many participants' contributions over the several years of the collaboration. Thank you to everybody. And it's interesting because when we first started this literature review, we saw several names come up through the findings of the literature review. And then as we were reviewing them, we realized that many of these were our roadmap collaborators. So it was really nice to be able to work so directly with people whose work was so impactful. So just to give an overview, our goal within the roadmap work package 4 was to evaluate disease modeling. And specifically, there were several objectives towards this. The first of which was a literature review on disease modeling in Alzheimer's disease. Now, Biogen had conducted a literature review and provided this to the roadmap to help aid the advancement of this deliverable. And the findings that you'll see are a combination of those that were identified in the literature review and also the subsequent updates that were discovered either after the literature review or by contributions from the different roadmap members, so things that have not been published yet. So what you'll see in these slides is actually a combination of systematic literature review and then what we like to think about as being a pragmatic review, which is getting all the sources you can get your hands on. I think pragmatic review is a very formal way of saying just taking everything you could find. So our objective for the systematic literature review, which I'll talk about first, was to identify, collect, and critically appraise the published data on models that evaluate long-term disease progression in AD and MCI, which is including MCI due to AD. And we're really interested in understanding this for both potential health economic models for disease-modifying therapy, but also to just understand the natural history and progression of the disease. And this literature review encompassed several types of primary research articles, both published economic modeling studies, because as you know, economic models use disease progression as the fuel or the engine by which the patients flow through the model. And we also considered just straight up theoretical, biological, and epidemiological models of disease progression, ones that were not necessarily assigned to a cost-effectiveness study. So we searched through a series of economic and disease modeling studies, and we also looked into the underlying data sources used for these. And the models through the preclinical AD disease staging were obtained through the collaboration that was not covered in the literature review. So we compiled the results of the literature search into a detailed document in order to help us critically appraise the models. And we had a few questions that we were considering within the framework of what does critical appraisal look like for these models. We wanted to understand how disease progression was commonly defined in the published literature, what biomarkers are used, what thresholds are used, were there events used, were any of these things used? Those are some of our starting questions. We wanted to help summarize what the published rates of disease progression were and what the mathematical or biological models might be, and including what are the transition probabilities that help communicate disease progression. And then we wanted to know what economic models leverage these disease models. So if we go back to the beginning and we think about progression, you know, it's important to think about progression as both clinical and biomarker changes. And progression information can be based on or expressed as either biomarker changes or clinical changes in the patient. So what that means is that biomarker changes are things like things that you would measure in a quantitative fashion, whereas clinical changes are also measured in a quantitative fashion, but they're based on clinicians' observations or clinicians' really qualifications of the situation. And these measures of clinical progression include measures such as the CDR, your clinical dementia rating. And there's two ways of scoring this, either your sum of boxes or your global scoring. It should be noted that CDR global scores can have 4 different categories. And similarly, your CDR sum of boxes scores can have 4 or 5 different categories, depending on the references that you're using. But it's possible to, and I should also add another category for preclinical AD. So we can comment that for the CDR, you're able to distinguish preclinical, mild, MCI, you're able to establish preclinical, MCI due to AD, mild, moderate, and severe disease. And this is able to assess your dementia severity as well as your pre-dementia severity, and it's valid across the spectrum of the disease. Another measure of clinical change is your MMSE, your mini mental state examination. This is the most commonly used test for problems of memory complaints. You'll see it in guidelines. You'll see it being used for the acetylcholinesterases, and it's been around for over 30 years. So this is a very, very commonly used measure. The ADAS-Cog, similarly, is another commonly used measure, but and this measures cognitive impairment. One thing to note, though, is that the ADAS-Cog has several versions depending on the disease severity. And this is important because as we look at some of the disease models, we noticed that there are different ADAS-Cog measures either being used as predictive variables or as your final variable that was being modeled. So the ADAS-Cog 11 is typically used in later stage disease, and more questions were added over the years to increase the sensitivity to earlier stage disease. So you'll see measures of the ADAS-Cog 12, ADAS-Cog 13, ADAS-Cog 14. And just as something that may not be readily apparent from the literature, ADAS-Cog versions that add questions to it do not necessarily add the same questions. So for example, one study, the ADAS-Cog 14 can have a certain composition of the extra questions. And in another study, it could be a different, slightly different composition. The validity is still, does not go into question. It's just a matter of how you interpret findings from one study to another. So we spoke a bit about your clinical measures of cognition and cognitive impairment. And another very important measure to assess is functioning. Because as we know, and I didn't give this introduction for this group because I know that this group is very much interested in Alzheimer's, and you're pretty much aware of the disease and aware of how it changes across the spectrum. So people on the phone understand that Alzheimer's disease is a progressive condition, which starts off as cognitive changes, but then progresses to functional impairment. And there's even behavioral, I don't want to say impairments, but behavioral changes that occur across the whole spectrum of the disease. Whereas the functional impairments gradually decline over the course of the disease, the behavioral impairments are can be a little bit more inconsistent. And which is why function is of interest to be measured, and especially as you think about using these models in health economic models for cost effectiveness, and thinking about how function and behavior tend to drive endpoints of interest to the payers, such as costs and burden factors. So it's very important to measure function. So there are several measures of function including your ADCS-ADL or your MCI variant. And these assess both basic and or instrumental activities of daily living. The instrumental activities of daily living are those that are initially impaired, whereas the basic activities of daily living are the ones that tend to be more impaired as the disease progresses. These are the more overt impairments, things like not being able to dress yourself, things like that. Whereas instrumental ADLs are more about things like, you're managing your list, managing your finances, things like that. The Functional Activities Questionnaire is also a very good measure that's used, and it's used across trials, it's used across registries. The NPI, which is a behavioral measure, is your neuropsychiatric inventory, and it's an assessment of behavioral symptoms and the neuropsychiatric components of the disease. Now, with respect to the biomarkers, there are several biomarkers that have been noted as associated with Alzheimer's pathology. And I think everyone, and what I should have put on here actually was the Jack curve, because I think everyone can probably picture that in their head right now. The curve that has about 4 or 5 lines with different colors, looking at the time and the slope and the growth of biomarkers as Alzheimer's progresses. It's said that people start depositing beta amyloid up to 20 years before your first clinical symptom is observed. And beta amyloid can be observed by either like a direct observation measure, your PET amyloid, which is your imaging of the amyloid on the brain, or by an inferential measure, which is your CSF A beta. And this is where the assessment looks at the level of A beta in the cerebral spinal fluid, the A beta pieces that are then deposited into the brain. So the depletion of of A beta from the CSF and the accumulation of of A beta in the brain are associated with Alzheimer's disease pathology. There are also biomarkers of neuronal injury, such as the tau, which is a downstream biomarker from A beta, and then also more broader measures of neuronal injury, such as hippocampal volume and FDG PET, and also SPECT perfusion. And there are also some more, I would say, exploratory or biomarkers that people are trying to understand a little bit more about and their relation to Alzheimer's disease, which are your inflammatory biomarkers, oxidative stress, and other biomarkers. So if we think about the role of biomarkers in patient identification, it's actually quite significant. And this is something that we should think about as we think about disease progression models, knowing that there may or may not be a role for them in the disease progression models, but knowing at least that they're important in your patient identification. So MCI, as you spoke about, MCI is the level of cognitive impairment that precedes mild dementia. But MCI itself is a heterogeneous disease because MCI is actually a clinical presentation of cognitive impairment. But the disease etiology that is underlying the cognitive impairment can come from many different types of diseases. About 40 to 50% of MCI patients have amyloid, and this comes from the JAMA 2015 meta-analysis. But that means that something like 50 to 60% of patients who have the clinical presentation of MCI do not have amyloid pathology. They have something else. May that be vascular dementia, may that be Lewy body, may that be no dementia at all, because these patients suffer from stroke, these patients have maybe had previous chemotherapy. There's many reasons why patients can present with cognitive impairment, specifically mild cognitive impairment, that clinical diagnosis, yet not have amyloid or another type of dementia. So it's really important as we think about the early stage patients who are symptomatic, it's really important to have the precision to understand that these patients are MCI due to AD or prodromal AD patients. And this may, and like I had mentioned earlier, this may or may not appear in the disease model per se. In other words, the biomarker may or may not be in the disease model, but you have to understand that the patients that the disease model is reflecting should be patients who have had the amyloid confirmed. Now, when we think about across the spectrum of AD, when we start getting into dementia, the dementia phase of the disease, your mild, moderate, severe dementia, the numbers who are biomarker confirmed, or I should say the numbers who have the AD biomarker and the AD dementia clinical pathology, the likelihood is getting better. You know, we see about 70 to 80% being biomarker confirmed. So while it would still be considered a best practice to have data on biomarker confirmed patients, the field is ripe with AD data sets that may not necessarily have this information. And we as a modeling community need to think about what that means. You know, how comfortable are we with the information that comes out of this, knowing that there's some margin of error? How big is the error? You know, these are just things that we're not going to necessarily come to answers about this today, but as researchers in AD, specifically about disease modeling in AD, these are things that we need to be thinking about. So we conducted a literature review, and we started to, we wanted to identify disease progression for MCI and AD. And you'll notice that the way we conducted these is we did not ask for specifically related to biomarkers. We wanted to see just what the literature was saying about these clinical phenotypes, knowing that the understanding what they reflect is going to be important later on. So we, you know, conducted a typical systematic literature reviews with multiple data sources. I should note that we did not look into conference abstracts because one of the goals of this review was to be able to critically appraise the methods that were used, and conference abstracts would not have provided the details that we needed. We conducted this literature review, as I mentioned, about 1.5 years ago. The review cutoff date, it was 2 years ago at this point, was March of 2016. But as I had mentioned, we've had updates within the roadmap and from contributions to other from other partners. And our outputs were basically very descriptive, description of the disease model. We mapped it to their use in economic evaluations. And we also, importantly, described the cohorts that these data were derived from, so we can really understand the generalizability of the cohort and the study or method used. So we identified 37 disease models in the literature. And as I mentioned, there's maybe 3 or 4 that were not identified in this study. And you can see that they actually cover, this is just a listing of the author and the type of model that it is. And you can see that there's actually quite a range of findings. And I have that summarized on the next few slides, so I'll get to that in a moment. But you can see, first of all, that it started in 1994 and it goes till today. So it's been many, many years of modeling across AD. And you can also see that it covers a lot of different endpoints. You know, we have MMSE, we have ADAS-Cog, we have CDR. We have the same data source contributing multiple endpoints. We have CRAD with your SIB, CRAD with your MMSE, CRAD with your CDR. So CRAD, MMSE Model 1 and Model 2, right? So there's a lot of different, a lot of nice work that's been done using the data sets that are out there. And I just wanted to show an example on this slide of the types of outputs that the report entails. And then I have a few summary slides coming up as well. But you can see that the description of this contains the model, basically what is it that's being modeled. Where, for example, in this example, this CERN ADAS-Cog model, we're looking at the ADAS-Cog. And you can see which variables are included in the model. And you can also see some details about it. You know, the investigators conducted a nonlinear stepwise multiple regression analysis predicting ADAS-Cog scores obtained after the first visit for each patient as a function of the patient's first visit score, the square of the first score, and time in months since the first visit, blah, 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 right? So you can notice that the variables included in the model are also described. And one of the things that, that we also looked at was, for example, whereas the Stern equation is valid for the untreated population, ... So this is saying that this disease progression model is reflecting patients who are untreated, so no symptomatic treatment. So if you think about how we use disease models today, you have to ask the question of, well, what do we do with this? Because today, 60 to 70% of patients are being treated with acetylcholinesterases. So just a point of context. And, you know, we also, so that was the descriptive overview of the model, but what we also did is, in this report, we flagged, or I should say we extracted key details from the papers. So, for example, to this point, you know, who's the population that this was derived in? Mild, moderate, and severe AD for untreated patients. I've seen examples of people deriving regression equations, let's say for the mild AD population, but then they want it to be used across the spectrum of disease. And if you think about your regression 101, right? You know, how appropriate is it to derive something in one population and then apply it to another population? So these are just things that we wanted to think about. You know, so we have, you know, this is a very good population. It's going across the spectrum of disease, but it's for untreated patients. So you have to think about what that means. With respect to data sources, it's a longitudinal study with 111 patients. So 111 patients, that's, you know, that's a smallish sample size, but honestly for AD patients, that's kind of within the realm of what we were seeing, with a mean and median follow-up time of about 2.5 to 3 years. It's also important to look at whether or not your patients are incident or prevalent patients, because as you think about the observation and what you're observing, you have to understand, what does that mean to me? If I'm looking at prevalent patients, the time that I'm observing their AD, is that the true amount of time they've had the AD or just what I'm seeing? So you just have to understand the context of that. So at a high level, there were 9 MCI models identified and 25 AD models identified. And the models with the AD patients did not incorporate biomarkers into the disease progression models. And 13 models provided transition probabilities to estimate disease progression. So among these, the CDR and the MMSE were the most common outcomes used to measure disease progression over time. And among these, the CRAD CDR model, the FU model, and several other models incorporated institutionalization or nursing home status, or the need for full-time care, into the model. And there's some differences in transition probabilities observed across the models as well. So 24 models characterized disease progression through modeling equations that related variables such as time, baseline cognitive function, and in some cases, different covariates to estimate disease progression in either MCI or AD patients. 3 of these models, the Samtani, the Q, and the second Samtani model, incorporated biomarkers into their disease progression model. So this is not, it's not necessarily saying that the disease models were derived in patients who are biomarker positive. I mean, for these studies they were, but furthermore, the biomarkers ended up in their disease progression model. MMSE and ADAS-Cog were largely the most common measures used to measure disease progression. And only one model, the EPAD model, incorporated institutionalization into the disease progression modeling equation. Interestingly, risk factors and biomarkers were absent from many of the earlier equations, but there were several more recent models that did employ some of this information. And then we have a list on here of some of the more complex models that the roadmap team had considered looking into. So some things that we wanted to consider. When we modeled the continuum of AD, it's important to have the nuances within the dementia portion of the disease as it's reflected in the literature findings. So we wanted to, it's important to look at not just dementia as a singular disease state, but really to look at mild, moderate, and severe dementia. Something that that necessarily wasn't clear to the team coming into this, to the roadmap group, but something that this systematic literature review really helped show was the importance of the nuance of the disease staging. And we saw that the disease prediction equations differed in construct, variable content, and data sources that were from what the model was derived. And we decided to look into this a little bit further. So we actually created a short list of models for validation in the roadmap consortium. And this was based on the existing models or on models that we obtained from the other members of the roadmap consortium. And we wanted to cover all the disease stages from preclinical to severe dementia. And we wanted to cover both regulator relevant endpoint and payer relevant endpoint, because we wanted to be able to think about economic analyses in economic modeling framework. And we also wanted to look at both simple models and disease models, because one of the great collaborators on this, Johan Vanderlei, from one of our collaborators in the Netherlands, he actually really cited the importance of having a very simple model just to make sure that your mechanisms for obtaining data, for the programming, just all of these details were really able to be ironed out on a very simple framework, rather than having the complexity of the model and the complexity of the operationalization of all of this work. So which is from this that we actually came up with a short list of models that actually reflected a range of considerations. So first of all, as I mentioned, we went through the disease progression literature review and identified some key models that stood out from this. And some of the key models that stood out from this were the Samtani, I'll start from the bottom up, were the Samtani model, the GWO model, and several of the MMSE time course prediction models. And what came out of this from the collaboration perspective was the green model was published, but the Handels adaptation of it is something that we wanted to look closer at, as well as the time to institutionalization model that Lilly had been developing, which is derived off of the PENTAG model, and I'll say more on that in a few slides, as well as the Novartis preclinical model. So we actually had, within the roadmap, a couple of months to basically deep dive into each of these models and to identify which of these do we think would be appropriate for this validation paradigm that we wanted to accomplish. And actually what I'll do here is I'll pick a couple of the models to just go through as examples for just to highlight. I didn't choose every single one of these models, but we'll just go through some of these just to give a sense for what do these look like, what are some of the considerations for these different models. One of the things I should just say is that I did not include in this slide deck in this discussion I would say the more simple models, which are those based on transition probabilities, because one of the things that we wanted to do was to validate the predictive modeling approach in a different data set. And while you can certainly do that with a transition probability, having a little bit more of a complex model was desired. So the models that I'll be discussing for the rest of this presentation are those based on regression equations, those based with multiple variables, but please note that there are a good number of transition probabilities that have been published, and these are very important to considering disease modeling and the implications that they communicate for how long people are living with Alzheimer's disease. So an overview of the Novartis preclinical model. Basically, this model is really focusing on the prevention setting and really using long-term longitudinal mathematical modeling to explore the natural course of disease in pre-symptomatic patients. And the reason why this is so interesting and so challenging is because if you think about, if you think back to one of the first things I said at the beginning of this talk, the Alzheimer's disease is defined by the symptoms of the disease, whether you have dementia, whether you have mild cognitive impairment that's associated with Alzheimer's pathology. But really, pathology begins 20 years before symptoms are present. So there is absolutely a silent or preclinical period where patients are developing, they're growing the pathology, they're on the road to symptomatic disease, but they are in this preclinical state. And there are certainly values to understanding how long it takes patients to progress through this preclinical state, but it's difficult to understand what do you track, right? It's like, what do you observe and what can you track? Which is why it's important to understand the natural course of disease progression in these pre-symptomatic stages. So this model was developed by Novartis with a couple of objectives, actually. One of them was to optimize trial design, because one of the challenges of clinical trials is being able to recruit patients into your trial who are going to have or who are supposed to have events within the time course of your trial. So this question about, if I'm running a 3-year trial, how do I know that I'm going to see anyone converting to an event of interest, much less how am I going to see how my impact is going to be on this? Is the treatment slowing the progression? Is it doing nothing? The scientists who design clinical trials need to have enough information to know that they'll be able to observe the hypothesis within the course of the trial. And also, as part of that, it's maybe part of the answer is, well, you can't include everybody. Part of the answer is there's going to be some people who are going to be converting faster, and those might be the people you want to put into your clinical trial. At the same time, this type of modeling is also used to basically communicate the disease progression. So if you want to think about health economic modeling, this could help you understand how fast patients are flowing through the model. So this is part of the reason why Novartis was interested in evaluating this and why it was brought to the roadmap for sharing. And the population for this was an elderly or an aging general population and those at risk for AD. And they used 2 U.S. disease cohorts, the RUSH data and the NAC data. The NAC data is the National Alzheimer's Coordinating Council, which is a really rich registry of many different U.S. sites with a consolidated protocol, like a core protocol. So you can actually answer a lot of really interesting research questions with the NAC data. If you haven't looked at the NAC data or looked at any papers with the NAC data, I highly recommend you take a look at it because it's a very rich data set for Alzheimer's disease. So Novartis, this preclinical model, looked into a longitudinal joint modeling of cognitive decline and time to event outcomes, where cognitive decline is anchored at the time of the first event. And they were considering over 20 years. And covariates included diagnosis of MCI or diagnosis of AD dementia. You can imagine diagnosis of MCI would be first, diagnosis of AD dementia would come subsequent to that, but also including things like demographics, age and education, genetic profile, APOE4 carriers, and cognitive scores. So just a few words on genetics and cognitive scores. So as people know, APOE4 carriers tend to have a higher risk of accumulating amyloid and therefore being diagnosed with an Alzheimer's diagnosis. This is, and I'm going to be very careful with what I'm saying here because I'm not a clinician. I don't think that this is because the APOE4 carriers intrinsically are have a worser outcome than those who are non-APOE4 carriers, but they tend to have the disease occurring earlier in life. So the way I like to think about this, and this is my non-clinical perspective, is that APOE4 non-carriers would have the amyloid deposition. It could just occur later in life, and they may die of some other comorbidity before the symptoms actually get to be to a certain state. Whereas that may happen 10, 15-ish years, something like that earlier in APOE4 carriers. So when you think about trying to identify populations who may be at risk at a younger age, APOE4 carriers are one of the people you would be looking at. And with respect to cognitive score, this is actually a really good question and a really difficult question, because these patients, preclinical patients, are by definition, they don't have symptoms. They don't have clinical symptoms. They're not mild. They do not have mild cognitive impairment. They may have some degree of subjective cognitive impairment, but it certainly not would register as an objective complaint and put them into the MCI category. So a lot of work has been done to identify which scales and which measures are going to be the best to actually detect this early and detect this accurately, which is why people have been looking at these composite cognitive measures, such as this APCC. And this model is looking at time to MCI and time to dementia, and again, changes in this composite cognitive endpoint. I said a little bit about the data sources, but I'll just say a few more words. The data sources that were used to generate this model were the Rush Alzheimer's Disease Center database, and the Rush database includes subjects who are older adults without known dementia at enrollment. So basically, they take people who do not have the symptoms of dementia, and they follow them longitudinally. And this gives the opportunity to observe patients who convert and who actually have dementia over the course of time. And they do have the components of the APCC available within their data set. Similarly, the NAC data includes subjects that range from cognitively normal to MCI and dementia as well. So as we think about preclinical disease, and as we think about MCI, and as we think about dementia, there is actually a lot of different factors that can be involved in this. And so part of the question is, what do you model as you think about modeling the progression? Do you model biological markers? Do you model risk factors? And do you model neuropsychological assessment, something more in depth in the MMSE, something like this APCC that we had mentioned? All of this to get to time to diagnosis of MCI or dementia. And if you look at, and if you look at the types of variables that ended up in the preclinical model, it included a variety of all of these different factors with differing contributions or weights of these different factors ending up in the model. So where this model is now is this model has been developed, and there's collaboration with the roadmap on the validation of this model in additional data sets. And part of this is to really help understand what are the key variables that are going to be most informative to prediction, and how do we optimize this. So the next model that I'll spend a few minutes talking about is a PENTAG model. And you can actually argue, there's a place to argue of, well, is the PENTAG model actually a disease progression model, right? And we actually had these discussions early on within the roadmap meeting, because on the one hand, the endpoint that you are modeling is not a clear disease indicator per se. It's not a clinical measure. It's not a biomarker measure. But at the same time, what it's modeling is institutionalization, which you can argue is a very, very important indicator and very relevant to Alzheimer's disease. So this PENTAG model, although technically may not be a true clinical disease progression model, as you might have thought of when we started this webinar, I would like to encourage us to really consider institutionalization as a very significant and relevant indicator for disease progression. So much so that this was used in the NICE assessment of acetylcholinesterases based on a Markov cohort approach with 3 states, basically pre-institutionalization, institutionalization, and death. And there are basically, to fuel this Markov model in the NICE assessment, there are basically equations that predict time to institutionalization and time to death based on various clinical factors. And the time to institutionalization and time to death include age, plus cognitive and functional scores, but only age was a statistically significant covariate in the original derivation of these models. But this data was very limited. It was based on data that's over 20 years old and a small cohort of 80 patients. So our colleagues at Lilly actually invested in an amazing data set, this GERAS study, where it is basically, and this study was used to help update this model, which is why I'm telling you about this. But this data source is basically a longitudinal study in 3 European countries, in France, Germany, and the UK. 18-month study originally in design, but they've been collecting data continually past that. I don't know exactly the schedule, but they do talk about having data beyond the initial 18 months. But 1,500 patients enrolled in this, which is a huge, massive number of patients for an AD registry, especially one that collects the richness of the data as they've collected. And although it's not described in the earlier papers, data on institutionalization and death was collected and continues to be collected. So they can constantly be updating the totality of the information on these patients. So this study includes patients who are community-dwelling patients with probable AD. So these patients do not have biomarker-confirmed AD, but as we had mentioned, there's going to be 70 to 80% biomarker confirmation. And these patients were given a diagnosis of mild, moderate, or moderately severe/severe dementia. AD dementia. And it was required that these patients have an informal caregiver who is willing to participate in the study, because one of the important things that this study provides is a lot of information on caregiver, caregiving time, caregiving burden, things like that, caregiver quality of life, and resource utilization. So we talked about the 3 different disease severities for the AD dementia. So one of the things that the team wanted to do with this very rich data source was to develop a model of time to institutionalization or time to full-time care. I think that actually in the GERAS study, they were looking at time to institutionalization, where they looked to identify which of the covariates from the whole range of GERAS data would be predictive of time to institutionalization. And they found that, not surprisingly, things relating to behavior and function were certainly included. You know, you have the NPI score, the instrumental ADL measure, the basic ADL measure, as well as cognition and age. And they used several distributions to try to fit the model optimally, the things that you would expect, exponential, logistic, Weibull, log normal, and gamma. And they also consider the AIC, BIC model statistics in this evaluation. And one of the things that that would need to be considered as you think about this is, let me just say a few words about this model. So one of the things that this model did really nicely is it used a very rich data source from 3 different countries to look into the time to institutionalization. It confirmed the use of the endpoints, the functional and the biomarker endpoints, which have been known to be determinants of quality of life, determinants of cost, determinants of resource use, determinants of institutionalization. So if you look in the literature, the history of AD literature, what this model did was it included things that you would expect to be predicted in the model. So from that perspective, it was very excellent. One of the things that is a little bit challenging, however, is that there are a lot of things that predict the degree of institutionalization, which don't have necessarily to do with clinical scores. Things like the number of institutions available in a given country is directly related to whether or not a patient will be institutionalized, but there's no room for that to be captured anywhere in the data set. Things like the cultural acceptance and the cultural willingness of taking care of an aged parent at home versus being in an institutionalization. So one of the things that and this is just my understanding of it so far, is that they're still looking into how this data may be used to understand institutionalization patterns across different countries. Because so far what has been looked into is the pooled data, but we still need to get a better understanding for what can be done when you look at an individual country from that perspective. So, I just wanted to give that framing. So, as we think about the time to institutionalization model using the GERAS data, there are several points that need to be considered. The follow-up has only about 5 years of follow-up, which with respect to longitudinal data is a good amount of follow-up. But if you think about the time course of AD, especially for patients in your mild or even your early moderate stage disease, it could be longer before patients are institutionalized. And the choice of the distribution is likely to have a considerable influence on the long-term outcomes. You definitely see that not just how well models fit, but the shapes, especially on the right tail, that ensue depending on which model fit is chosen, can actually have big implications on the right side of the tail. And this is something that's actually seen in oncology as well. This is a common factor in disease modeling and extrapolation, but one that we need to take into account as we consider this data as well. The choice of the endpoint was time to institutionalization, and we spoke about some of the challenges of this, and in particular, there's limitations because not all patients will be institutionalized. You could also think about time to full-time care. So, you could then ask questions about, well, what does full-time care mean? Do you put full-time care in the same model as an institutionalization model? So there's a lot of different nuances around this that people can explore. But it is recognized that under the strictest sense, in economic assessments, institutionalization is typically more meaningful to payers than full-time care, because institutionalization can be something that is paid for by the payers. So another model I wanted to share with you is the Handels MMSE model. And this is actually a model that was chosen for the simplicity. And I'm not going to say simplicity because it's an easy model or it was very easy to derive. But this model was chosen because of actually the limited number of data elements that you have in the model. You pretty much just need MMSE, age, and time as key predictors in your model. So when you're thinking about, or when the team is thinking about validation of models and looking to develop a system for validating models readily, this is actually a very good model to use because it's not only informative from a adding to the field perspective, but it's also going to be a good platform to evaluate the validation mechanism. And I personally like this model because one of the things that that I like about it is I believe this is an incident AD patient, which is actually very important to consider. It's a very important detail to consider as you think about disease progression, especially as you think about intervening earlier in the disease course. Patients are going to have the full spectrum of disease to live through. So, and identifying patients earlier in the disease course. So the fact that this model exists when incident patients is, I think, very good and very interesting for the field. The green model is also a very, very important model to the AD community. This is, just in brief, this is looking at AD from a more complicated perspective. This is basically saying that the hypothesis of this model is to say that to call patients mild, moderate, and severe is a little too granular. What we really need to understand is the nuances of the disease. Are the patients, what is their level of expression of your different cognitive, functional, and behavioral symptoms? So to say that a person with mild disease, let's call them a 111, where you have 1s, 2s, or 3s assigned for either cognition, function, or behavior. A 111 could be very different in concept from a quality of life and from a research use perspective from a 113. So someone who maybe has a 1 for cognition, a 1 for function, but a 3 for behavioral symptoms. You could imagine there being a very different implication if you have very severe behavioral symptoms. So this model was developed to basically try to give more granularity to the experiences of the AD dementia phase. And Handels had taken this model and had adapted into it a preclinical and an MCI phases, which basically lead into this elegantly complex 27-ish state. I think they ended up with 20 states at the end of the day, Markov model. And basically, this model was derived from the NAC data because you need a large number of patients to be able to derive transitions for all these different states. And this is a similar source as the Spackman model, which you would have seen listed in the list of models. And you'll notice that the transition matrix is looking at from state to state transitions, but does not include mortality estimates. This is something that will need to be applied per state as a reduced number of patients in the state from the prior state because they died. So you don't necessarily have transitions to death that you'd be modeling, but you would have transitions between states. And I believe this might be the last model on the list that I'm speaking about, which is the Samtani CDR sum of boxes model. And just to highlight that the Samtani model is an important model to consider because not only is it a very elegant description of disease progression, but it also is looking at the CDR sum of boxes, your clinical dementia rating scale sum of boxes. And this is a very relevant endpoint because this is an endpoint that's approved by the FDA and supported by the EMA for clinical trial development. And if you look at some of the clinical trials in mild cognitive impairment that are enrolling, they're using the CDR sum of boxes as the primary endpoint. So as we think about the relevance of this, as we think about people's interest in this, this is definitely something that's going to be evolving as we're looking earlier and earlier in the disease, specifically in the MCI stage of the disease. Now this is interesting because from a clinical perspective, this single measure includes both cognition and function, whereas previously in your mild and your moderate clinical trials or moderate and severe clinical trials, a co-primary endpoint was required of cognition and function. And this single measure encompasses both. So again, as you think about disease modeling, we have not yet seen examples of disease progression models looking at, with the exception of the preclinical APCC, which is a composite cognition endpoint. We have not seen a composite endpoint containing cognition and function. And while the CDR is certainly not a composite, does not reflect a composite endpoint, it does reflect a complexity of what the patient is experiencing in a single summary measure. So it's with this perspective that the CDR is actually quite a nice measure because it considers both cognition and functioning, but it also has multiple domains that it uses to assess these. So it's actually quite rich in information. And it's for this reason that the CDR can be considered as an appropriate scale for tracking disease progression in the early stages of disease. And just a few notes about this Samtani CDR model that was derived. First of all, I was looking at changes of CDR sum of boxes and not CDR global. As I mentioned, the CDR sum of boxes is your endpoint in these trials. And also, if you look at the parameters that are included in this model, you actually see a range of inputs that are predictive of CDR scores. You can see, as expected, you would see your baseline score, right? Because the baseline score is very much, is always your starting point. You know, people know, it's very well known that disease progression rates can vary over the course of Alzheimer's disease. So including your baseline scores is essential. But also, one of the things that they looked into is including biomarker information, basically hippocampal volume, and also whether the patient has mild AD or not. Interestingly, things associated with like risk factors, you know, as we think about risk factors for disease progression, comorbidity, there's many comorbidities. They say healthy heart, healthy brain, right? Just a very, very broad statement. So there's been a lot of interest in looking into how comorbidities influence or are whether they are associated with disease progression. So this model looked into that with the perspective of co-medications. This is an indicator of comorbidities. And interestingly, this model did find significant the inclusion of a particular, not just your CDR sum of boxes score, but a particular clinical measure, which is a delayed logical memory. And the reason why I wanted to bring these details up, or not to talk about, oh, is it a delayed logical memory, or is it a trails test, or anything like that, but it's more to show that there are different contributions in this model to the CDR progression, looking at a range of concepts, both overall staging, your CDR baseline scores, to specific aspects of disease or performance on tests, which may indicate risk of progression, other risk factors such as comorbidities, as well as neurodegeneration markers as well. So it's with this that I think I'll wrap up this talk and talk about the overall path to the model validation, which included a list of the simple models and the complex models, and as well as understanding some of the challenges in real-world data access. So with this, I'm happy to end the presentation, and thank you.